Hi, everybody. Sorry for the late pause. Had a bit of internet connectivity problems the last few days in my area, the fiber. Um, yeah, so hopefully that we can do one today and you guys will enjoy it. The uploads may be a bit erratic over the next month or two. I just want to thank Dr. Wadia. She's actually helping to clean up our Google links and hopefully transfer it to a YouTube link. So there may be some interruptions where we don't have a chance to upload. And this may continue on for a little while. And once it's all sorted out and all uploaded and uplinked and whatever you call it, then hopefully, yeah, you guys will have better access to um, all of the older videos, which I know a lot of people have been struggling with recently. So hopefully that will get sorted out. And yeah, in the meantime, I'll still upload as I have a chance. And if the uploads are a bit erratic, just forgive me. We may have some weeks, we may not have on the other weeks. And yeah, we'll take it from there. So anyway, getting into today's, we got a bit of a nice one. Wouldn't say a difficult one, but one that as soon as you see it, you may, oh God, you know what's going on here. So, we follow our usual things for the ECG. Next week, hopefully, we'll do another topic, not necessarily ECGs. Been doing a lot of those recently. So, as usual, we'll analyze the axis, the rhythm, the rate, and we'll analyze them each zone. So I think anybody looking at this would immediately think, okay, this is a rhythm abnormality, and you'd be right. So we'll be covering those a little bit. So let's just have a look. So we have a 55-year-old man who presents with syncope. So what are the causes of syncope? There's quite a few. But the easiest way to think of syncope is the blood's not getting to the brain for whatever reason. Number one, blood pressure is low. Number two, blood pressure is there. Or let me rephrase that. So blood has to get to the brain. Blood gets to the brain via the blood vessels or tubes. So either not enough blood is getting into the tubes, or the tubes are blocked, or what you call it, the tubes are backed up. That's another one that can be used. And, those are the best ways to look at it. So thromboembolic events, CVA is very common, cardiovascular, you're looking at, again, thrombi, you're looking at emboli, then you come down to the heart and you're looking at valvular abnormalities, shock, all of those things. And of course, you have vasovagal and things like, which also cause generally, hypotension and decreased amounts of blood entering the brain. And this often leads to syncopal episodes. And of course, you have intrinsic problems within the brain itself that can lead to syncope. A common one would be like absence seizures that can often lead to what looks like syncopal episodes. So, there's a lot of things to consider. But in any case, you get this patient, 55 years old, he is fainting all the time, and you're not really sure what's going on. Even he's not sure. So as part of your workup, and ECG is always part of a syncope workup in a patient. So you as a good emergency room doctor, or just a good doctor wherever you may be, even if not in an emergency room, you now come and say, all right, let's put an ECG on for you, sir, and this is what we see. So we immediately say, okay, there is something cardiac going on over here. So let's have a look and see. So, did I give it away? All right, sorry about that. So just forget that. So let's start first with our, what you call it, let's start first with our axis. All right, so let's draw it here. So for those of you who remember, we have lead 1 here, lead AVF here. All right, and we're going to look at how they join up to us. Now, I know there was a problem with some of these basic ECG videos that we had released. So hopefully this is one of the things that will get sorted out. So let's try now. So let's start looking at lead 1. All right, so lead 1 is positive. So that means if we look at it, that means electricity is moving towards lead 1. So it's either in the left axis or in the normal axis. It cannot be here. All right, so it's not an extreme right or a right axis. Okay, and like you see, if any of this seems confusing, then what you call it, let's go back to the basics and have a look at those. All right, and then we look at lead AVF. So lead AVF is negative. So here's lead AVF. Let me just change the color here a little bit. All right, so let me just change it to that. So we know it can't be there, can't be there. And because electricity is moving away from lead AVF, we know it can't be here as well. So we've got a left-sided axis, all right? Okay, so we've got that left-sided axis, and let's look at our rhythm. Now, this is where it gets interesting, okay? So first, let's have a look at our P waves. So how do our P waves look? Our P waves in terms of morphology look relatively okay. And in fact, if you look at our P waves, they're quite regular if you measure them out, okay? So your atrium is functioning properly if you look at this, all right? So we've got this, let's draw it rather, okay? So let me draw from a peak of a P wave to a P wave, all right? Oops, what am I doing here? Let's see it. I'm trying to draw it myself. Okay, so let's change the color here. Okay, so that's one P wave to one P wave. And then if we look at the other one, P wave to P wave, you can see it there. Let's change the color. If you look at the third one, P wave to P wave. Let's take another one. Let's change the other color. Let's make it green. So what I'm trying to show is that if you look at all of these, you notice the lines are relatively equal. So from P wave to P wave is relatively equal. So that means that you actually have, technically you have what they call a sinus rhythm, because sinus rhythm is determined by the atrium, but overall we don't have a sinus rhythm. But if you call it an atrial sinus rhythm, that's fine. So you've got these P waves that are regular. So the atrium is functioning normally. Now, just to jump at one, just like a little side note. So by contrast, we see the ventricles are not firing regularly. So that means there's something blocking the atrial, the atrial action potential or the atrial firing from reaching the ventricle. So this means we have a block. So this should already be running in your mind. I'm dealing with a block. So there's 4 types of blocks: type 1, type 2A, type 2B, or Mobitz type 1, Mobitz type 2, and complete heart block. So we're dealing with one of these 4. That should already be running in your head. Now the question is for you to figure out which one. Okay, so let's have a look and see. So we know our P waves are fine, and we know they are regular. So the next part of it is we always look at our PR interval. So let's have a look at this again. So let's annotate these. Let's make it a bit thicker, and let's make it red, and let's make it a line. All right. So let's look at our PR interval. So remember, that's from the peak of your P wave to the peak of your R wave. Okay, oh, sorry, a little bit off there, but okay. Now, if you look over here, you'll see there's nothing, right? So we know that there's nothing there. That's fine. But let's look at this one here. So let's look at that from peak to peak. Let's look at the ones that we do have from peak to peak. All right, sorry. I'm also, all right, and here we have nothing. All right, so there's a missing one there. So that's where the block is occurring. And if you look from there to there, then we have another P wave to another R wave. There we have where the block is occurring, okay? And then let's look. So because it's a rhythm disturbance, that's why I'm just taking a bit of time just to show you guys, because I know people get confused with these things all the time. And I'm going to show you how simple it is to actually figure out in your own head what's going on, okay? Right, so let's take that one. So remember, we're drawing, so our horizontal lines are showing our PR interval basically, and then the vertical lines are just showing where the block is occurring. So what's the one thing that you notice about all the PR intervals? They're regular. They're absolutely regular. Now they may be slightly elongated, but they are regular. Okay, they are absolutely regular. So in other words, when the atrium is conducting to the ventricle, the time it's taking from the atrium firing or the SA node to fire and then to pass its signal onto the AV node is exactly the same, no matter where it is. All right, so it's not changing. Your PR interval is constant. Okay, and what happens is if you watch this, you've got 1, 2, drop, 1, 2, drop, 1, 2, drop, 1, 2, drop. So what it's telling you is that for every 3 atrial conductions, one is being blocked completely. Now what happens is it's not going through at all. Okay, so this, and then it's leading to a slightly widened QRS complex, right? Which tells us that even though the signal is going through, it's not being conducted very well. Okay, so that's causing an elongation over there. Okay, so what do we have here now? Let's look at the 4 blocks and see what we should have. Right. So what is a type 1 block? So let's do type 1 block in blue. Sorry, I'm just trying to change that, and it's just not going. Sorry about that. So what happens is that in a type 1 block, which can be just normal as well, the PR interval is lengthened. All right. So in other words, there's nothing else. And you don't have any drops. All right? So if this was a type 1 block, we would see something like that. We'd see a PR interval that looks like that. All right. When you got to your QRS complexes, where we see a drop here, there would actually be a QRS complex. Now let's just assume it looks the same. All right. I'm going to try and do my best over here. Let's just assume it looks the same. So you'd see exactly the same thing. So there wouldn't be any misses. There would just be prolongations. Right. Now let's try a type 1, because what we have here is actually a type 2. Right. So I'm going to explain to you the difference now so that you can see it. So what happens in a type 1 is that, in a type 1, so first degree heart block is this. So what happens in a Mobitz type 1? In a Mobitz type 1, what happens is you have a PR interval that's normal, all right? Then it gets slightly longer, all right? Now, just for the sake of illustration, then it will get slightly longer again. So we may still have a QRS complex that shows here. I'm just going to put that in there. And then eventually what you would get is you would get a miss. So you would see nothing where we have it here. So you'd have small, big, big, and then a miss, and then this would probably repeat itself. It would be small, big, big, and it would carry on like that. Okay. So type 1, just prolonged PR intervals, no dropping. Type 2, elongating PR intervals with an eventual drop, all right? And then the cycle restarts again. Type 2, Mobitz type 2, consistent PR intervals with a drop. Okay, so in other words, it doesn't elongate. It stays exactly the same. Whether that's longer, normal, that's not the important thing, but it's consistent, and then eventually it completely drops. Okay, and then let's do the last one. So in the last one, let's try and do it in green. In the last one, there's no correlation between your QRS and your P. So in other words, you'd have a, let's just draw, okay, let me just try and draw it out rather. Not really sure. Don't think it's really allowing me to draw again. Okay, not really sure how to get back to that. But anyway, all right, so let's just say we have a P wave, all right? And you'd have, example, another P wave. I'm just trying to draw it out as best as I can. And you'd have, for example, another P wave here, right? So this is a complete heart block now, a grade 3. Then you may have a QRS complex here. So let's draw a nice big QRS complex like that, just to represent a QRS complex. Then you may have nothing. And then you may have another one here, all right? And then you may have one, again, just about, you may get another QRS complex here. You may have a P wave but your P waves will be generally regular. And then you may have another QRS complex here. So in other words, there's no correlation between the P waves and the QRS complex. There may be drops, there may be no drops, there may be lengthened, normal. Nothing really matches as compared to the others, all right? So the others, there's still a relationship between the atrium and the ventricle. So in type 1 or grade 1 AV block, it's just that the signal is taking longer to get from the atrium to the ventricle. In Mobitz type 1, it's taking longer and longer and longer, and eventually it drops. In Mobitz type 2, it's taking time to get there, and eventually it can't get through at all. Okay, and then the final step is a complete heart block, where the atrium fires, but the ventricle never receives the signal. Now, the other way to remember them, and another easy way to remember them, in grade 1 and Mobitz type 1, you generally have narrow QRS complexes, right? 99% of the time. And in Mobitz type 2 and complete heart block, you tend to have widened QRS complexes. So that's another way of remembering it. All right. So we figured out here that we've got a Mobitz type 2. We've got consistent PR intervals with an eventual drop. Now you can see we have three atrial fires for every 2 ventricular fires. Okay, so that tells us that it's a Mobitz type 2. Okay, so what looks scary is not actually that scary. The problem with Mobitz Type 2 is that this is going to become a complete heart block. And what's happening is in between here, he's becoming hypotensive because of this erratic or this irregular heartbeat. He's probably becoming hypotensive, all right? Okay, let's look at each what you call it. Let's look at the rate. So the rate would be measured from there to there. You're looking at about 60. Now, what does make it a bit difficult is that you generally have these odd waveforms. So where you would see Q waves and things like that, there is a possibility of infarction. So that may be what triggered this off in the first place. But there can also be left bundle branch blocks. There can be a whole lot of things that can get into that. So I'm not going to stress you guys out about that now. We're just going to have a quick look and just to see if there's anything else that pops up. All right. So it's mainly these Q waves in this these inferior leads. There's not much else here. The one other thing to note here is that you've got these prolonged QT intervals, which we should also always look at. Okay. Now, the one other thing that you can note on here, if I remember correctly, is that there just seems to be a bit of left ventricular hypertrophy because we've got a left-sided axis as well. And you can see how we've got evidence of that with this prolongation and these tall waves in AVL. All right. So I hope that makes a bit of sense. So let's see. We've got a sinus rhythm with second-degree AV block type 2, Mobitz type 2. It is about 60. Left ventricular hypertrophy with repolarization abnormalities and QRS widening, right, which is normally what occurs. So we have upright P waves in leads 1, 2, 3 AVF, inverted P waves in AVR. This is a bit more technical as far as atrial analysis goes. Now, it's not as important for us in the emergency department. More when you get into your physicians and your cardiologists, they worry more about that. But we still need to know it. And hopefully I want to have a section just on atrial abnormalities at one point. Okay. So the atrium is going as about 90 beats per minute. Mobitz type 2 AV conduction is diagnosed here based on the following. So regular atrial activity, which we saw, and some P waves are not conductive. All right. In all of the conducted beats, the PR interval remains constant. So remember what we saw: consistent red lines, consistent PR intervals. The atrial activity was consistent, but occasionally there would be a drop beat. Okay. Here they talk about the ratio, so 3 P waves for every 2 QRS complexes, left ventricular hypertrophy that we had seen here as well, and it's associated with abnormal repolarization, right? So in other words, a left bundle branch block. Okay, slight prolongation of the QRS complexes, left axis. So what are the causes of the left axis? And these are just in general. So you get left ventricular hypertrophy, which we have, left bundle branch block, which we have, prior inferior wall MI, which we also had, left anterior fascicular block, which we've covered before, and you should go back and check on it. Although it's not really present here. Ventricular ectopy, paced beats, Wolff Parkinson's White, these are all the different things. But in this ECG, it's more related to LVH. Okay. So let's just have a look at it again. All right. So this is basically what they were talking about. So it's the fixed PR interval, the horizontal lines, which do not progressively change from beat to beat. Ultimately, an atrial impulse is not conducted, resulting in a P wave without subsequent QRS. So that's what we've discussed already. All right. This form of AV block should be considered malignant, with concern for progression to third degree or complete heart block. So what's the problem with this? Eventually, a patient becomes more and more hypotensive and eventually goes into complete heart failure, poor ejection fractions, is basically unable to keep up with what the body needs, if you really look at it. So at the end of the day, this is the reason for our patient having a problem. So what does this patient need? This patient needs a pacemaker. So the pacemaker is going to go in there. It's going to provide an atrial beat directly to the ventricles, bypassing the normal conduction system. And that's going to allow it to function like normal. Okay, so that's how we treat these patients. Can you treat these patients in an emergency department? Yes. You can do paired pacing. depending on how bad the patient is. In his case, he was just having syncope episodes. We wouldn't do it. Okay, you can do a what you would call it, venous pacing, intravenous pacing, which is where you have it looks similar to a CVP, if you've seen one of those. It goes directly into the ventricle, but it's basically just a stopgap measure until you can get a pacemaker in. Right? So we'll cover that hopefully when we cover some more emergency department topics. So this is just a bit of a joke just to finish off. And if you guys have any questions, you're more than welcome to message me. Yeah, and hopefully I'll try and keep the lessons going until we get everything sorted out with the YouTube channel. And yeah, we'll take it from there. But if you guys have any questions, feel free to message me. And hopefully the next one will be more of a emergency department topic, or we went quite far with radiology and then stopped. So I'm hoping to continue with those. All right. And keep well, everybody. Bye.